Good morning. My name is Corporal Zach Davis, and today we're going to go over Section 1, the General Assessment and Supportive Care. Just a little preview on this website in case you need to get here so you can look through these protocols, go over them, whatever the case may be. The website is okctulomd.com, as you can see at the top browser bar, whatever you call it. And that will pull up this page right here. And then you just click on treatment and protocols, individual protocols. And then today we're going to start in section 1, which is the general assessment and general supportive care. So you'll click on that, and then you'll just start here with the medical general assessment. So where you click on the medical general assessment, this is pretty topwater stuff with just it's general assessments for adults and pediatrics. So anytime you're looking through these protocols, there's a yellow box. These are your treatment priorities. These are very important to know, and you need to know the order of them and exactly what they're saying, and there'll be time amounts, stuff like that all in here. So make sure you pay attention to anything in a yellow box. So starting out, number 1, you have your assessment. Always, just like in EMT school, when you first started EMS, you have scene safety. So your scene's got to be safe for you to be able to enter. You have your proper PPE, you do your primary survey, then your secondary survey when it's appropriate. Number 2 is your primary survey care. Initiate cardiopulmonary resuscitation if it's indicated. Open the airway, rather that be a head tilt chin lift, jaw thrust. Support oxygenation, ventilation. Support circulation, dysrhythmia care, rate control, hypotension care. Number 3, minimize scene time if critical case unless working cardiac arrest. We'll get into much more detail about how we work cardiac arrest within this OMD system. But if it's not a cardiac arrest, we're going to try to minimize the scene time and get them to the hospital as quickly as we can while still giving them the appropriate care. Number 4, en route care. Reassess all primary care, support oxygenation and ventilation, vascular access, your secondary survey, and keep the patient warm to avoid hypothermia if that's indicated. And then your hospital per destination protocol. There's a protocol at the very end that specifies where we will transport all these patients. And we will go into much more detail once we get to that point. So again, topwater stuff here, just talking about, when we went to EMT school, just starting out, when it's a non-trauma patient, we will use the ABC order, which is airway, breathing, circulation. So airway, number 1, evaluate the patency and mechanics of the airway. Is the patient able to oxygenate and ventilate on their own, or do they need rapid intervention to assist their airway? Breathing, number 2, expose the chest as required to accurately assess the mechanics of respiration. So you're just counting how many times they're breathing. Note the rate, depth, and pattern of the respirations, and if in any degree of respiratory distress or effort. And then we auscultate breath sounds bilaterally. We will obtain pulse oximetry readings. In all honesty, we should probably be doing this on all patients, regardless of their complaint. It's very easy, very simple, not hard to do. It will assist us with their pulse oximetry reading and if they need oxygenation. We will be using capnography as well with certain patients, and this is mandatory when we intubate the patient, and we will talk about that in further detail later on. Circulation, number 3, the adequacy of the patient's circulation is best assessed first by evaluating the level of their consciousness and mental status. Then we'll assess the location, rate, and character of the pulse. We'll check a blood pressure. Typically, when we check a blood pressure, we want the first one to be a manual blood pressure, just to make sure it's as accurate as possible. Sometimes the cardiac monitors are not the most accurate, but if we get a manual first, we'll be able to see if the cardiac monitor is within reason. We'll apply the cardiac monitor on certain situations. The only exception to this ABC rule is in cardiac arrest. We'll talk about cardiac arrest more in section 4, but in cardiac arrest, we'll aggressively initiate chest compressions and search for shockable rhythms at the appropriate intervals, and so we won't always just go straight to ABC. We scroll down here, medical general assessment, adult and pediatric. This is just showing a chart of the GCS scale. GCS is pretty important to know. You need to know how to count a GCS, how to be able to obtain a patient's GCS. GCS scale goes anywhere from the range of 3 minimum to 15 maximum. You can have no less than 3. You can have no more than 15. So looking at this chart, you got eyes, motor response, and verbal response. If there's no response at all in any of these categories, they'll obtain 1 point per category, and then it just goes up from there. So make sure you look through this and know how to obtain a patient's GCS. After addressing the ABC order in most medical patients, including evaluating and addressing any life-threatening conditions, you want to minimize your scene time. This does change a little bit with cardiac arrest, but again, we'll talk about that in Section 4 and how long we want to stay on scene for cardiac arrest, when we want to stay on scene, when we want to initiate transport. But for your basic medical trauma patients, we want to minimize the scene time and initiate timely transport to an appropriate emergency department in a setting of a time-sensitive medical condition. We'll complete a head-to-toe assessment of the patient. If the patient is relatively medically stable, we'll obtain what we used to call a sample, just a history of a past medical problems, medications, allergies, hospitals that the patient's used in the past, stuff like that. We'll reassess the patient pretty frequently. On a stable patient, we'll reassess the patient every 10 minutes. On a unstable patient, we will reassess the patient every 5 minutes, especially if hemodynamic changes are occurring. The 5 minutes is the absolute maximum for an unstable patient. You can reassess vital signs within 5 minutes or under 5 minutes if you need to. You'll assess and treat per symptom or illness-specific protocols that follow in this protocol set. So when we start talking about pediatrics, a pediatric is considered anyone you're equal to 18 or less. And so if they're under 18, then they will be considered a pediatric patient. This does kind of get confusing because you want to treat a patient to their size. Just because they're 15 doesn't necessarily mean they're not 6'4", 250 pounds. There are pediatric patients that are that big. And so just reading through this, just keep that in mind. As we come down here, vital signs do vary with age. In general, the younger the patient, the faster the respiratory rate, the faster the heart rate, and lower the blood pressure. And so just looking at this chart here, we're not going to go through every single one, but it kind of gives you an idea of the heart rate for premature neonates, 6 months, 1 year, 3 to 4, 5 to 6, 7 to 8, and 11 to 12. It shows here the heart rates, the respiratory rates, and then your systolic blood pressures. This is very important to know as far as later on when you start to take your test. But the average normal systolic blood pressure can be estimated by 80 plus 2 times the age of years. The lower limits of a normal systolic blood pressure can also be estimated by 70 plus 2 times the age of years. So I would definitely know that and remember that. The following table can be used to calculate the Glasgow Coma Scale. Like we said earlier, the GCS in pediatric patients, especially those under 4 years of age. Most pediatric patients above the age of 4 will be able to be assessed using the normal adult GCS table. So that is Section 1A, and again, to get here, you just go to okctulomd.com, click on Section 1A, and we will get through the rest of these later on.